morning, everybody. Welcome to Medicine Grand Rounds. Before we get started, I'll just we'll just start with acknowledgement. I respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So just a very quick update before I hand it over to the team. This, of course, is our current wave in terms of confirmed positive cases. You can see that we are at the peak. There might be some signs some days that things are getting better, but for the most part, we are currently living our peak of COVID-19 related to Omicron. Next slide shows our hospitalizations. So just to give you some perspective, we have seen an exponential rise in Edmonton Zone hospitalizations. So last week when we presented this, Edmonton Zone was sitting at approximately 340 hospitalizations total with 32 in ICU. This week we've jumped up to 576 with 37 in ICU, and Calgary, of course, is also the same. A lot of this is related to outbreaks institutionally, but nonetheless, we are seeing anywhere from 5 to 10 admissions at various sites a day. So it's pretty significant. Next slide. So this is our early warning system, and those who know me know I tend to be a glass half full type of person, and I see a little flattening there. So that's why I thought it was important to put that up there to say, there are some signs that things are peaking in the zone in terms of positivity rates, and perhaps plateauing in terms of hospitalization. Never turn your back on COVID. We've all learned that, but nonetheless, these are some positive signs to hang on to. We know that hospitalizations do lag for a bit, for at least a couple of weeks after the peak. So next slide. This is the Canadian situation. I mean, once again, hope is on the horizon when you look at what's happening across Canada, particularly in Ontario and Quebec. They have reached their peaks, and we're seeing that hospitalizations have plateaued as a result. So, I truly believe that this is just a matter of us hunkering down, I guess, getting through this. And the only way we're going to do that is together, because the end will be in sight. And to that end, with this tremendous increase we've seen, there has been a multiplication of COVID wards, and I'm just so proud of the level of professionalism and altruism that's been shown within our department, with people stepping up to do COVID wards. And so we thought this would be a great rounds to just give people a little update on how to do that. And so with that, I'm going to hand it over to our Chief of Medicine at the university site, Dr. Fraulein Morales. Thanks, everybody.
Thanks, Norman, and good morning, everyone. So I'd like to start first by introducing all of our panelists, and I'm really grateful that they allowed us to engage them in this in a week's time. So Saiful Anwar, Katie Collins, as well as the IPC group. We've invited Bonnie Granfield and Stephanie Smith to help us answer your questions today. Next slide, please, Andrea. So really the objectives today is to give you an update on any new information on PPEs and COVID therapies. Describe a typical day as an MRP in the COVID wards, as some of you will be doing this for the first time. And as a practical aspect, we would also like to demonstrate the use of the COVID-19 admission order sets for adults, which Dr. Anwar and his group has worked on to make life easier for all of us. So really, I'd like this to be informal, practical, and we just want to show you the practical aspects of the pandemic response of the department. So as an update, medicine ward coverage, we're up to COVID ward 5 currently. COVID ward 1 is in 5D3, COVID ward 2, 5D4, COVID Ward 3 and 5D2. And we have the subspecialists and the pulmonary and, the HCP group manning those services. We moved GIM to 3 Echo 2 just so we could cohort the subspecialist in the fifth floor. And when COVID Ward 5 is currently a mixed unit being manned by GIM, but will later be transitioned to the combination of rheumatology and pulmonary, as well as endo and GIM on alternating weeks. So we are at that point. COVID Ward 6, if we get there, is going to be in 5 Fox 3, and we are currently working on the roster for that. Next slide, please, Andrea. So this is just an example of the schedule and the roster and backup system. And I'd just like to warn you, if you're, let's say, committed to COVID Ward 5 for the week of January 24th, and that ward is not fully open, but we have an illness somewhere, my second backup roster would be you, with the first backup roster coming from the division that is assigned to that unit. So if Seyful gets sick next week, Raj will be responsible for giving us someone for COVID Ward 4. But if there is no one really because illness struck or isolation requirements, I will go to COVID Ward 5 to help in COVID Ward 4. Okay, next slide, please, Andrea. So as that's a really good segue to this. We need illness and isolation coverage. And as I said, I've asked you guys, and I think Narmin has supported this, having a COVID roster and a sick roster. Be ready to be activated anytime, and we may need to move you from one ward to another. If you're nervous, we're all nervous, ID and GIM consult services are available for assistance with COVID and medical management. I would suggest that if your question is purely COVID therapies, then please consult ID. But if it's COVID therapies plus medical management, it might be more efficient to just involve GIM then, so just one service. You don't have to worry about being on call overnight when you're on the COVID units. We have created a very robust overnight coverage with a pandemic MRP, which is often an R5 or a staff person. I think Raj was on Monday. We have 2 clinical assistants from HCT and GIM. And the core internal medicine program has generously provided us with a night float resident Sundays to Thursdays from 9 p.m. to 9 a.m. They may call you if acute issues or acute illness comes to your patients, but normally they would be responsible for overnight calls in the wards as well as admissions from the emergency department. Next plan is to engage all of these other people. And again, I'm working on surgery and ICU as well as the emergency department. Next slide, please. Okay, so for the sake of time and so that we could give you more time for questions and answers and demonstration, I have collated all of the links in this presentation in this slide, and Andrea will be sending that to all of those who registered today. So in this one, you will be able to see how a UAH designated COVID unit looks like. Stephanie Smith created a video on this, and there will be some updates on that, I believe. Some things that we're not doing anymore, and some things that we need to do now with the Omicron variant. And Steph will talk to that in a little bit. And we have also the PPE and precautions, which are slightly different for a full COVID unit versus a mixed COVID unit. The biggest difference being wearing the N95 throughout the COVID unit, if it's a full COVID unit. Differences with gowning and donning and doffing with a full COVID unit versus a mixed COVID unit. So for the full COVID unit, the donning and the doffing stations are actually designated outside of the unit, whereas the mixed COVID units would be beside the patient's room who are found to be COVID positive, and there will be markings on the floor as well for that. Next slide, please. Admission to the COVID wards. Next slide. I will be giving this to Katie now.
Good morning, everyone. So currently right now, I just wanted to talk a little bit about how COVID patients actually get up to the units. So GIM is responsible for triaging all of the COVID positive patients. So anybody that comes through the emergency department, whether they be COVID positive from the community or test positive in the emerge, that'll be the ED GIM consult team that'll be responsible for triaging those patients, and then they'll be allotted to the separate COVID units. For internal transfers, either from another ward or service or the intensive care unit. We've been having a few more of those transfers lately, just unfortunately with some of the outbreaks that have occurred. But if one of your patients tests positive and it's between 8 a.m. and 5 p.m., just page the medicine bed coordinator to let them know, and they will assign that patient to one of the COVID units. If it's between 5 p.m. and 8 a.m., just page the on-call GIM physician, and they'll be able to let you know about the process for actually getting that patient over to a COVID unit. And just as a bit of a reminder, if one of your patients tests positive for COVID on your unit, please give handover to the receiving physician, who will be one of the COVID docs. And likewise, if you are on the COVID unit and you receive a patient randomly to your unit, please contact the previous physician for some handover. In terms of external transfers, right now it's actually happening through Rapid for anybody coming from a community site or another hospital, and it'll be the GIM on-call physician who's responsible for that. Next slide. So I just wanted to go through a little bit of what a day might look like on one of the COVID units. So we are expected to be in-house between 8 a.m. and 5:30 p.m. However, of course, that doesn't mean you have to be on the COVID unit for that entire time. So usually your day will start with rapid rounds with the allied health team. So for 5D2, D3, and D4, that'll be at 8:10 between Mondays and Thursdays, and then 9:10 after grand rounds on Fridays. I did touch base with the physician who's currently covering 3E2 and 3D4 COVID units, and it sounds like right now they haven't actually established a set rapid rounds to review the patients. But if you're on one of those units, I would just suggest touching base with the unit manager, charge nurse, and unit clerk to review any of the patients and discharges. So during rapid rounds, you'll have the opportunity to review all of the patients with the multidisciplinary team and can kind of get everyone's input and feedback about what's going on with the patients. And this is also the opportunity when you'll be able to talk about discharges and discontinuing isolation. So right now, if you are discharging a patient, you've deemed they're good to go home, then if they have completed 5 days of isolation and they're double or triple vaccinated, they no longer need to isolate in the community. If they're unvaccinated, they'll have to complete 10 days of isolation in the community. And if they were in ICU or they're immune compromised, that'll be 21 days that they'll have to isolate once at home. And so the unit manager will help you keep track of all of these, like who's actually still needing isolation. And if someone is needing isolation in the community, there's a couple of forms that the unit clerk will help you fill out. For discontinuing isolation, so a lot of our patients have been admitted with other things and require ongoing hospitalization. So I actually heard from Stephanie Spitz and Bonnie Granfield just yesterday that 2 days ago, it actually changed. So if a patient is double or triple vaccinated and they were admitted for non-COVID reasons, then they can actually come off of isolation after 10 days. Again, if they're unvaccinated or had COVID pneumonia, respiratory symptoms, they still need to complete 14 days of isolation in hospital. And then likewise, if they're in ICU or immune compromised, they'll still have to complete the 21 days of isolation. I know that was kind of a lot of information, but Andrea's going to send that information out with the slides as well. And then after rapid rounds in the morning, you'll have your whole day to see the patients, round on anybody that you'd like to on the unit. And then usually after I was done rounding on everyone in the morning, I would sort of leave the unit just to give yourself a bit of a break from the N95 and PPE. And then that provides the opportunity just to write orders and do notes and things kind of outside of the unit. And then usually I would come back to the unit and sometime in the afternoon, depending on what's going on with the patients, usually between about 2 and 3 p.m., and just follow up on anyone who might be acutely sick or any tasks that needed to be taken care of from the morning. And then at 5:30, we've been doing handover to, as Fraulein mentioned, the pandemic MRP and the clinical associates, as well as some of the core internal medicine residents who've been kind enough to cover. And so Seyfel or Fraulein will start a chat between 5 to 6 p.m. It'll actually include all of the clinical associates, the MRP who's covering overnight, as well as all the COVID docs. And it'll just help you be able to know who to hand over in the evening time. Next slide, please. In terms of the visitor policy, it has been changing. I'm sure you've noticed on a bunch of the units. Some of the outbreak units, of course, don't have visitors, but right now on most of the COVID units, there are currently 2 designated support people per patient who can visit one at a time. So just one person per room at a time. For patients on OptiFlow, we haven't been allowing visitors to go into the rooms, but there can be a designated support person sitting outside of the door for visitation. Fraulein's going to go through a lot of the COVID therapies that we have now, but I just wanted to put a little bug in your ear just to remind you about the importance of establishing goals of care early in admission, especially as these patients can decompensate quite quickly. Next slide, please. And just in terms of what's available on the unit, so we have high flow oxygen, as you know, as well as OptiFlow is available on all of the COVID units. Unfortunately, we don't have non-invasive positive pressure ventilation, so mainly BiPAP available on the units, except for there's 2 eye care beds on 5G3 that have the capability to have isolation, and we can do BiPAP on those units, and that'll be cared for by one of the GIM physicians on Team B. Next slide, please. All right, well, I'll hand things over to Fraulein again.
Thanks, Katie. So these COVID therapies that I'm about to present is really just a summary of what's available to us currently. And they were collated by the COVID-19 therapy working group from AHS, to which I think a lot of our ID docs are a member of. So if we could click on the first, next slide, please, Andrea. Okay, so I'm sorry, Andrea, can we go back to the previous slide? So the current guidance for management of adult hospitalized patients with COVID-19 is a 9-page document that actually goes through the indications for each of the medications that I'm going to be talking about. So as I've been saying, when I'm going to the COVID unit, the Sunday before, I would be reading this up just to make sure I have all of those things quickly in my head. But the next table, next slide, please, Andrea, is what I carry around with me in my phone when I'm on the COVID wards, or actually every single day, because I still get questions about them. So I love this table. It's what I call COVID Management 101 or COVID Management for Dummies. But it's organized into severity of illness and then the antivirals that we have available, immunomodulator therapy, as well as neutralizing antibodies. So for most of our patients will be in this first blue boxed area because they would be in hospital and requiring oxygen. So for these patients, remdesivir is recommended, and it is a formulary drug, and we will be showing you how to do these orders later when we go through the admission order sets when Seyfel does that. For immunomodulators, we need to give them dexamethasone if they're on oxygen, and then tocilizumab or baricitinib are recommended if a patient is requiring more than 6 liters of oxygen to achieve oxygen saturation of greater than 90%, or if they're requiring OptiFlow or BiPAP. Again, these are formulary, and you will find them in the order sets. The neutralizing antibodies is a little bit less clear, and I wanted to give these a few minutes because there are a lot of questions about them. Regencov or casirivimab, imemdivav, is recommended for patients who are seronegative for COVID-19 antibodies, are severely immunocompromised, or have had not been vaccinated. So a little bit more work to order it because you're going to have to go through all of that. But we should not order it anymore because they don't work in vitro for Omicron variant. So we should not be really using this drug anymore because 90% of our isolates, I think, are Omicron right now in the province. Sotrovimab is usually an outpatient medication that we recommend for certain high-risk patients who are admitted for non-COVID reasons. So for GIM, let's say you have somebody with a diabetic foot ulcer and they come in with fever, they were tested and came back COVID positive, but they're not needing really any oxygen and they don't have COVID pneumonia. So if they were in the outpatient, they would have actually qualified to use sotrovimab. So then you can give that, and pharmacy will allow you to order it. One word of caution, if you're already giving somebody remdesivir, dexamethasone, and toci, you should not be giving them sotrovimab as well because they automatically do not qualify because they're already really ill. However, if let's say that patient with a diabetic foot, you've given them sotrovimab and then in 2 or 3 days of admission is now needing oxygen and is getting sicker, then of course you should consider giving the dexamethasone, toci, and remdesivir. At the bottom of this slide, another frequent question, and I think integral to COVID care, just because of how many patients get venous thromboembolic diseases, is anticoagulation. So 2 things to remember, and just 2 doses, 75 units per kilogram and 175 units per kilogram, which is prophylactic and full dose anticoagulation dosing for anticoagulation. The current recommendation, or at least the current practice, is to give the full dose anticoagulation to anyone needing oxygen up to 15 liters. This would exclude patients who will need to go to intensive care or have multi-organ failure, or if their Has-Bled score is high to begin with. We recommend to give it for 14 days or until you discharge the patient. Everyone else, at the minimum, should be getting the prophylactic dose of the tinzaparin. Another common question is antibiotics. You know, as with anything COVID, there's a lot of changes and rapid evolution. So a lot of our patients in Ripple 1 and Wave 2 were actually started on antibiotics from Emerge, and we were very hesitant to stop them when they got up there in the wards unless really their chest x-ray remains clear and their oxygen requirements remain stable. But currently, we've been much better with antibacterial stewardship, and we've been avoiding giving this unless we think really there's high chance that the patient has a bacterial superimposed infection. So let's say they have COVID, lobar pneumonia on the chest x-ray, or their chest x-ray in general just doesn't seem consistent with COVID-19 pneumonia. And usually the radiologists are really good with guiding us with that if you want to call them and review the x-rays if you're uncertain. The only other reason that I would give antibacterials for COVID on somebody with COVID-19 is if they're not doing well in my unit. So I've given them all of the treatments that I could give in the arsenal, and their oxygen requirements continue to go up or they're becoming more hypotensive. White count is not a really good gauge because most of the time these people are already on steroids and their white count tends to go up. CRP is quite helpful. So you could base it on that. But again, you know, examine the patient. If they're just looking toxic, looking sicker, then maybe you should cover them for bacterial pneumonia or hospital-acquired pneumonia. Next slide, please, Andrea. So these are the doses. Katie is a bit obsessive and she wanted me to make sure I did this. So remdesivir 200 milligrams IV on day 1 and then 100 milligrams for 4 days. Dexamethasone is 6 milligrams PO or IV for 10 days or until the patient is off oxygen. So if they're off oxygen by day 5, you can stop it. Sometimes what I do before stopping it is I ask the nurses to do a road test around the unit. And if they're not desaturating on the road test, I would stop it. But if they did, then I would give it an extra day. Again, tocilizumab IV or baricitinib PO for people requiring oxygen more than 6 liters. And I will just not go through the neutralizing antibodies. Next slide, please, Andrea. So these are the updates, and I've talked about that. If there are more questions about it, we can entertain them during the Q&A portion of the rounds. Next slide, please. And again, I've already talked about this. Next slide, please. So we'll go through Connect Care. Saiful and his group with Bob Hayward have worked really hard in giving us some guidance for this. And again, it makes being in the wards a lot easier. So Saiful.
Thanks, Pauline. So I'm sharing my screen now to walk you through the training module of this Connect Care for confidentiality reasons. So patients I'll be showing you, these are not live patients. I've deliberately put on the calendar phase of the Connect Care because we have some subspecialists who predominantly do outpatient. So once you hit the list portion, it will bring you to the inpatient list. And while you're working on inpatient, on right side of the screen, there is a star button. You can star it, and whenever you open your Connect Care, it will bring you to this screen rather than to calendar and then back and forth. So you can always default it which face of the screen you want. So I'll be walking you through some of the basics before I take you to the Connect Care order sets. So first, how to get list of COVID units. So on the left side of the screen, at the bottom, you'll see available list and identify University of Alberta, and then look for provider list. So under provider teams, you will be looking for COVID ward. So for example, COVID ward, you right click on it and you can send it to either one of the list if you have made a list of COVID units, or you can set as save as favorite. And then once you go under favorite, it's there. And once you open it, your COVID ward 1 patients will be there. So identify your patients. It will tell you location, name, ULI number with attending physician, and what service the patients are admitted. It's of utmost importance that your patients are added to that particular COVID unit list. So by right-clicking, you go into treatment team. You can either take over the patient when you're taking over, or you can reassign whosoever you're handing it over, and you can do pre-reassignment. So let's say on Sunday you're giving handover, you can do pre-assignment for Monday, and you can put time 8 a.m. So that capability is available. And then other important thing is adding them to the COVID ward 1. So for example, if I want to add COVID ward 2, which I should not because this patient belongs to COVID ward 1, but let's say if the patient is going to team D of GIM, then you look for team D, general internal medicine, it will be added to that team. It will appear once the patient is moved out of your unit and you have given handover to team D staff, then you can remove them from COVID ward 1. So I'll remove them from GIM team T because the patient is currently under COVID ward 1. The other important thing I will talk about under the transferring is service. But when the patient gets admitted under yourself, make sure they belong to your service. For example, for Line, Katie and I are internal medicine, so we make sure that the patient is admitted under general internal medicine, and I'll show you how to update that. Going into the chart, and I'm showing you a patient who is already admitted, which you will see majority of the population because you won't be admitting. But overnight COVID physician residents, they will be admitting. So it's highly encouraged that they use COVID admission order set because we have worked very hard to bring in everything which Furline talked about in terms of therapies and all the admission order sets. but it can be pulled in when the patient is admitted. So it's not like you cannot pull in. So just type in COVID, and at the top you'll see COVID-19 admission adult. There is another one for ED, but we're predominantly using adult because these are admitted patients. Once you're into the order set, if the patients are already admitted and you just want a clean blank set, you can always clear all order on right side of the screen. Because on right side of the screen, you see that there are already orders which are defaulted, which we want at the time of admission to save time. And nice thing is it all tell you, for example, this patient is admitted, it shows you which are duplicate order. So to avoid duplication, you can discontinue because you don't want to multiplicate work. So for this one, I will walk you through right now with this, but then I can show you the clear order thing. Some of the links which Fräulein was mentioning, so they are available in the order set under clinical decision support. So you don't have to look into your emails or pull up PowerPoint. So you can directly click from here, manual COVID-19 order set inside AHS resources, guideline from AHS, how to manage COVID sick patients. And some of the calculators are given to have some guidance which direction your patient is going, and can have some idea if the patient is showing any high risk morbidity, mortality, and can gauge if the patient would be needing ICU level care. And at the time of admission, we encourage that we click on these, that nurse update PCP for admission, and then frailty score if needed. As Katie pointed out, goals of care. So at the time of admission, it's important to be done. But if it is not done and you don't want to pull the order set, you can again type in the order set GCD and it will show you the goals of care. Again, isolation is by default, but you can, if you want to start, you can start contact and droplet, or if you want to discontinue, you can just write an order, discontinue isolation, it will show you. So in the training environment, it's not showing the default, but look for discontinue isolation option. Under discontinue isolation option, it will prompt you about different items, but generally I would say as per IPC resource manual, and I generally leave some comment here so that the nursing staff would know why I'm discontinuing. Moving down, diet orders. So again, in terms of diet, multiple diet options are given. So for example, you want to order regular diet or dysphagia diet. And then under regular diet, you have some patients with diabetes or heart healthy. You have those options. You want to restrict salt. You have nephrology patient, low potassium, renal dialysis or no dialysis, religious belief, and other gluten-free or other options. All details are available. Under patient care, you have multiple options of this glucose monitoring, and depending on where they fall in the category, patients requiring steroids certainly need monitoring if they don't have any history of diabetes. So I'll be choosing the middle order. So with that, they will be, nursing staff will be doing QID glucose monitoring for 48 hours, and then if it's stable, it will be done daily. But with history of diabetes, they will continue on doing QID. And if the sugars are staying high, especially more than 10, it's highly encouraged to continue with their oral hypoglycemic or basal bolus insulin therapy. And elderly or in low GFR patients need to be careful with insulin to prevent hypoglycemia. And then again, height and weight. This is another portion which I highly encourage patient care assessment to contact research nurse. So what you have to do is maybe just ask from the patient consent that if they would be willing to participate in the research. And then we have great researchers who are very well interested, and some of the patients have participated. So it improves research protocols for our university hospitals. So you just have to get consent, and the unit clerk will notify the research team. They will provide further information to the patient. If you are not able to find this information, feel free to send a secure chat to Dr. Wendy's Legal, and her team will take care of it from there. Again, some Foley catheter options. Again, it's encouraged that check on daily, try to get rid of extra lines, want to reduce infections. And again, in terms of respiratory, if you want it between 88 to 92% in someone who is hypercarbic, 92 to 96 in regular population, keeping it on higher side, for example, someone with ACS or someone with a stroke. We generally don't see pregnant population at U of A, but you can get someone with less than 20 weeks of gestation. So again, the goal is to keep oxygen saturation on higher side in pregnant population. Some of the lab requests, these are some of the initial lab requests, hematology, chemistry, and coagulation, cultures and gases. And same for virology at the time of admission, COVID swab, and if ILI panel needed. And then the repeat set of labs, CBC, creatinine electrolyte, CRP, and D-dimer will be already ordered for you. D-dimer would allow you some looking some data about if they are at high risk of they are at high risk of VTE anyway, 29% higher risk of VTE in COVID population. So along with the lab data and clinical assessment daily for DVT or ongoing hypoxia, tachycardia, then Wells score is also given here, and radiological imaging options are also given in the order set. Options for ECG, options for fluid, ringers, and NS are some of the common fluids, but if you want to choose any other type of the fluid, you can order it from the browser section. We have kept two separate areas. One is for VTE prophylaxis. So here it will show you prophylaxis. In the live environment, there will be a hard stop with this treatment options where you're seeing. In the training environment, there is no hard stop. The reason is because we had some instances where DVT prophylaxis was not provided, and there was we are aware in Calgary reported of massive PE. So choose one of the option. If they have contraindication to anticoagulation, choose the option of SCD. And if they don't have contraindication medication, then you can choose high risk or renal dosing. Again, there is guidance given there in terms of the dosing. And then moving on to medication part, which Fräulein has talked in detail, but it's all incorporated here in the order set with guidance. Starting at the top, bacterial co-infection. So we want to incorporate antibiotic stewardship. So start only when you're suspecting bacterial pneumonias, otherwise avoid it. And again, links are given for guidance. And then in terms of anticoagulants, so here is a section for therapeutic anticoagulation. And again, here important is to see if your patients are what sort of weight is there. So if someone is weighing less than 40 kg or greater than 330 kg, that's given at the bottom. And the system will automatically calculate for the weight patient is on. So for example, in this patient, 75.3, it's automatically calculating for you, so you don't have to pull your calculators out. But make sure that if someone is less than 40 kg or more than 330 kg, then you choose the other option of tenzaprine. Then moving on to antivirals, again, guidance is given, consider acutely ill. So, and it will automatically take you to initial dose of 200 followed by 100. And again, guidance is given. There is a hard stop if your patients are meeting the criteria or not. If they are meeting the criteria, hit yes. And then similarly for 100 milligrams. Moving on, we have options of steroids. Again, we have outlined oral IV route. Preferred is always oral route, but if they are not able to take by mouth, then injectable options are available. If they cannot take the pills, then the liquid option is also provided. It's listed as injection, but it can be given orally. So that's why you see three different options. Then moving on, we have immunomodulators, which Fräulein pointed out. So tocilizumab or baricitinib. Again, guidance is given there. So you can pull it from there and the links are given. Now, in the training environment, you will notice that different dose options are given, but now as per working group, it's 400 milligram, and you would have to click yes if they are meeting the criteria. Then baricitinib, we have a few different options given. One is 4 milligram daily for regular renal function. Then we have two other doses depending on GFR. So more than 30 GFR is 2 milligram daily. and then less than 15 actually would be 2 milligram every other day. Between 15 to 30 would be 2 milligram. So those options are given for you as well. And then the other option was for Keserimab. Again, guidance is given, and it's listed here not for use in confirmed or suspected Omicron variant cases due to documented loss of neutralizing. So all the reminders are there for you in the order set. At the bottom, we have outlined consults. So if you want to consult any services, any specialties, allied healthcare services, and discharge instruction. So this is mainly about COVID order set at the time of admission, but when patient is already admitted, as I alluded, you can just, after opening the order set, you can hit clear all orders. It will just clear the order set orders. It won't clear your already admitted order set. So now this will look completely clean order set, and you're only interested in immunomodulators or antivirals, so you can just go to that section and order your medications there. So you necessarily don't need to write tocilizumab in the browser and look for it. You can always go to the order set and order from there. We are working on mini order set that will mainly be involving the medications to use rather than having a full order set, which you are seeing right now. Now, next I will show you quickly about charting for ConnectCare for COVID patients. Progress note will be type 1, or you can always type progress note if you don't remember that. And then for service, for example, for myself, it's general internal medicine, or I remember the number 112. And then we have our division have made this COVID progress note, .covid note, which I will show you where you can pull up. There are multiple ways of doing charting, problem-oriented charting, and then there are sidebar for COVID-19 charting. But we want to keep it simple so that everybody can survive their week of rotation on the COVID unit. With that, it will pull in the basic information. At the top, we have outlined some generic identification data, but corrected with their presentation. It will pull in their past medical history, their vitals, and then vaccination, onset of symptoms, variant, and then treatment. So it's easy for you. You just have to click in what they are on. And then by hitting F2, it will take you to the next issues. So that way you'll be able to do your charting. I'll show you here under personalization section how you can pull. So under personalization, you go into my smart phrases. You can look out for my name, for example, and then you will see COVID note. For example, like my profile will have multiple a smart set, so you can just type in the search box COVID note, and then it will appear, because right now there is only one. As we're running short of time, I'll quickly walk you through transfer, because you might be dealing, before I go to transfer, under the order section, if you're receiving any patient from ICU, you will have transfer orders under sign and health section. So this is your active order activity, but if you go into sign and health, you will have to release orders which ICU team would have put for you. So you can select and then release it. There will be a release button here. It's grayed out because right now there are no transfer orders saved for this one. And then if someone is being transferred out of your unit, then you can do transfer orders. Or if someone is being discharged from your unit, then mainly it's the activity in discharge orders. If someone is being transferred from the facility, we have two different. One is ConnectCare facility. The other one is non-ConnectCare. So for example, for non-ConnectCare transfer IFT order note, you just create note and it will pull in all the active orders. Before you do that, make sure you clean your active orders, because it will be pulling all the data from your active orders. These are the main things I wanted to show. One thing I would point out here, for example, if someone is on Remdesivir and has improved and wanting to go home, so let's say they've completed 3 days of Remdesivir and wanting to have 2 more days, please utilize virtual hospital service. So they can provide additional 2 doses of Remdesivir at home rather than staying extra 2 days in the hospital. Fräulein, over to you.
Okay, thanks, Saif. Bonnie? Andrea, can we go to the next slide? So if you have questions about remuneration, please email me or your division directors. They will have answers for you. Next slide, please. Again, I'd like to put a plug in for the COVID-19 Pandemic Plan Google site. It has all of these information as well. So whichever one is easier for you to access would be great. Before I end the presentation, I'd like to involve Bonnie and ask, Bonnie, any clarifications with PPEs or any new guidelines you wanted us to know about?
I would just mention that if you do pull up the video about the COVID units, there have been a couple changes that have occurred. So the core is really considered clean, and we would not wear gloves when in the core, just in the patient room. And anytime you have that direct patient-to-patient care, you should be changing your gown. I don't know if Dr. Smith would like to add anything.
No, I think that the main things, if you are watching the video that we did at the very beginning of the pandemic, we have learned what works and what doesn't, and so just there's a few little tweaks, and you'll be guided by the PPE coaches and everything. So I don't want you to worry too much about about all of that. But yeah, the main things are more use of N95 masks, and then no gloves except for when you're going in the room. And then we'll be working with you in terms of, the whole around the issues of discontinuation of isolation. So again, this isn't a decision that you have to make on your own. We'll be helping with that.
Okay, Katie, do you want to take questions now and go through the Q&A box?
Yeah, for sure. All right. So there's a few questions in the chat, which I'll try to address as well, and then questions in the Q&A box. So maybe I'll direct this question first towards Saiful. Are there any shortages of these COVID therapeutic drugs?
Sometimes we do have shortages, and Fräulein and I receive updates, and right away we update our COVID physicians who are working that week. So we keep them updated, what is available, what is not.
And I'll just add to that for today. I just double checked with one of the head pharmacists, and she said, we've had tocilizumab has been on quite a bit of shortage lately, although we are intermittently getting doses, but we have all of the other drugs as of right now. All right. Next question, I will direct towards Fräulein. If someone is being transferred to the COVID ward from another ward, will they arrive with the COVID admission orders?
Probably not, Carrie. Most of these patients are coming from non-GIM or non-ICU wards. And so if they were admitted, let's say, in nephrology for dialysis or whatever reason, and then they were found to be COVID positive, the staff doctor there may not have had time to do those orders. So we do ask you to review transfer orders and check what medications are appropriate using the COVID admission set. And that's why we've made it so that you could actually pull it out, not just on admission, but anytime you need it.
Great, thank you. And then I'll also direct this question towards Fräulein. How are the redeployed subspecialty residents going to be remunerated?
I am not sure how they're going to be remunerated. I think if they're signing up as a pandemic daytime MRP, they could be remunerated. But if they're working as part of their program and as part of their rotation, I don't think there is a separate remuneration from that. I would suggest you speak with the program directors because they've been given instructions on where we can redeploy people and how we can redeploy them. So I imagine there would be something about remuneration there as well. I'm not sure if Narmin is still around, if she can answer that question better for me. Probably not. Okay.
Okay, and we can I can look into that as well, and I'll have Andrea send that out with the rest of the documentation. All right, I'll direct this next question towards Safel since I think you're typing an answer. But the question is, if you're doing inpatient consults on other services, sorry, the questions are just moving around here. Oh, sorry,
Yeah.
Safe. Okay.
So, yeah, the answer was the question was about the consult. If you're entering the consult, should you call the services or not? So for better communication, it's also important after you enter the consult. For example, if you're entering ID consult or pulmonary consult, give them a call, why you're calling them and reason for consult, so that they would know you're calling them.
Excellent. And Safe, maybe I'll have you answer this question as well. If a patient is deceased with COVID, admitted for non-COVID reasons, but incidentally positive, are there any specific guidance on filling out the death certificate in this scenario?
Depending on what is the primary reason for death that you will outline. If you think that the death was not due to COVID, for example, if the patient was already admitted due to massive stroke and they were found to have incidental COVID, then obviously the cause of death would be due to massive stroke if they were declining due to that reason rather than COVID.
Thank you. And Fraulein, I'll direct this towards you. If a patient is possibly deteriorating, does ICU prefer earlier to be called when clearly consultation is needed, and who is to be called?
Okay, great question. So yes, they prefer to be called earlier. Actually, early in the pandemic, we were calling them at 6 liters. I think we've become a little bit more comfortable, and now we've proven that maybe early intubation is not always the way to go. So I'm calling them usually at 10 liters, or if there's a rapid deterioration, if they were at 2 yesterday and suddenly they're at 8 this morning, that's a big jump. So I would call ICU. Who do you call? I put in a Connect Care consult, and I also call on the phone and ask for the ICU resident doing consultations.
Great. And there's just a question here. Is there a good summary of the evidence guiding our current treatment options? Erin, yes, there is. There's a really good summary, and we will send out all the links to anyone who's registered for this afterwards. And it will have the whole table and all of like the more nitty-gritty details of the criteria and dosing and that sort of thing. There's another question here. And Bonnie, maybe I'll ask you to answer this question. What percentage of Omicron is in the hospital right now versus other variants?
Well, for example, on 5D3, so our 18-bed unit, we had, we had 1 out of 18. So I would say, like, for the majority of the cases that I've seen right now, it's Omicron. There's like barely any floating around on the units.
Okay, thank you. And Saiful, I'll ask you to answer this question. Is there any preference given to tocilizumab over baricitinib if supply isn't an issue?
I don't think there is any preference one over the other. So both would be reasonable depending on the supply. The option, better option with baricitinib is oral option, but it's longer duration, 14 days. So compared to tocilizumab, which is intravenous and shorter duration. These are the two main things.
Great, thank you very much. So there's another question here, is there a link to the PPE presentation that you could send? As some of the students are not very comfortable with the donning and doffing protocols. That's an excellent question. So there is a link that will also be sent out, and it's a YouTube video of Dr. Stephanie Smith showing the donning and doffing procedures with a few other people. And so it's a really good resource for students to see, and residents, and even a good refresher for all of us as well. Just looking through some of the other questions here. Is there a specified code team, or should we be prepared to run the code? Fraulein, maybe I'll ask you to answer that question.
Again, there used to be a specified code team because they wanted to make sure that patients could get intubated early enough. I don't think we've changed that. Having said that, we hardly ever had to call a code in the COVID units because most of the time we've been really good partnering with ICU. And so I don't think we've had a code recently in the COVID units. But if there was and you call the code, there is a special team, I think, for COVID patients.
Excellent, thank you. Um, and this is a really good question, and this comes up quite often. So maybe I'll have all of us can weigh in on this question. Maybe we'll start with you, Saiful. Do you ever get requests for non-evidence-based treatments from patients and families? And do you have a recommended approach in handling these situations?
So I did not receive it directly, but because of medicine site lead, I got involved. One of our colleagues did receive requests for IV 100,000 vitamin C injection and ivermectin, and family also wanted their naturopath to come to the hospital and provide those multivitamins. So in that scenario, we did ended up involving AHS Legal for multiple reasons. One, naturopath, they don't have the license to come to the hospital plus use our IV lines. So it would not define which IV complication happened. So majority of these issues we saw during Delta waves, and we were facing a lot of patients unvaccinated. So it is always challenging in those scenarios. And if you're coming across, feel free to let your side leads know or let Froline or I know. And then we do end up involving the hospital leads plus AHS Legal if needed.
Katie, do you want to answer how you handled those requests, like
Sure.
speaking with
You know,
family?
I've actually had a few of the requests, mainly for ivermectin. So one of the things that I often say, although it's a little bit of a cop out, is after establishing relationship with the family, et cetera, just explaining that we don't have good evidence for it and whatnot, but also saying that our governing body, i.e., the CPSA, sent out a document that said, that's outside of our scope and we should not be prescribing ivermectin. So I just flat out say that given that I won't be prescribing it. And most people have actually been very receptive to that, what I found. Fräulein, do you have anything to add about that?
No, I don't. Are there more questions, Katie? I think
Yeah,
you
there's a
have,
few
yeah.
more questions. Let's see what time it is. Okay, we have a few more minutes. This is a kind of an interesting question. Fräulein, I'll maybe ask you about this one. A colleague at the Royal Alex had a patient who clinically had symptoms very consistent with COVID, but refused to get a COVID swab. Any thoughts on this?
So we actually had the same thing happen at the university. And I remember, you can't tie them down, can't stick something down their noses or their throats without their consent. So what we ended up doing is just treating them as if they had COVID, not with treatment, but meaning we had to isolate them in a private room, but we couldn't send them to the COVID unit because, of course, if they didn't have COVID, you didn't want them exposed that way. So, in that case, we treated that patient as if they required isolation in another unit outside of the COVID wards and just waited to see if, fortunately, that patient actually did well and we didn't have to initiate treatment. Steph, did you want to add anything to that? Because I know you guys were also involved in that case.
No, I think you've summarized it.
Katie, any more questions? Because I'd like
Yeah,
to give,
there's
oh,
a
sorry.
few more
If,
questions, but
yeah.
we can always, stay a bit longer or have, we can send out the answers to these questions. Maybe I'll answer this one. What are the current rules around students on these floors and level of residence? So currently students and residents are allowed both to see COVID patients, but we don't have any students or residents other than the core internal medicine senior residents who are covering the overnights actually seeing any patients on the COVID units. Having said that, they might be asked to see a patient in the emergency department who tests positive for COVID, and there's no other specifications around that. They're allowed to see those patients as of right now.
Okay, Katie. I think we'll go through the questions. If anyone wants to stay after, you're very welcome to stay. But I just wanted to make sure I give Stephanie a few minutes to give us an update on anything she thought we might have missed. And I'd also like to announce that they are presenting, so Steph and her group are presenting Grand Rounds next week on Omicron Update. So, okay, Steph.
Sorry, thank you. Yeah, honestly, I don't really have a whole lot more to add. We will be presenting next week, so I think that we'll be able to kind of cover things. But in terms of, the precautions, the isolation, all that kind of stuff, we're certainly here to support you. So that should not be a big concern in terms of, there's a lot, obviously, of new stuff when you're going to be going onto the wards and you're not used to it. So that should be the least of your concerns, because, certainly we'll be following along with you. And if there's questions about, how long someone needs to be isolated, those kinds of things, then we're around to help. And in terms of PPE, again, you will have coaches there. Please listen to them. They're really there to support you and to keep you safe. So again, we all forget, we're all busy, and they're just there as kind of helping to remind you to make sure that you're donning and doffing properly. So I think, all of those, the IPC kind of stuff, should not be too difficult to manage for all of you guys.
Okay, I guess, Katie, if there are no other questions, we'll end there. And again, the panelists are happy to stay for a few more minutes for anyone who may still have questions. And you can directly ask us, or we will submit them and collate them. Thanks,
Yeah,
everyone, and have a
thank
good day.
you.
Have a good weekend. Stay safe. Don't get COVID.